Tengo el gusto de presentarles a la doctora Kathleen Doyle de Massachusetts General Hospital, que nos va a platicar un poco de la escena internacional, y también mencionar que la doctora Julia Rowlands del National Cancer Institute de los Estados Unidos no pudo estar con nosotros el día de hoy porque National Cancer Institute está cerrado por la guerra política que está pasando en los Estados Unidos. Entonces formamos parte de los que han perdido de esta situación de no estar en pro de todo lo que es la protección social y salud, pero a la vez apoyamos todo lo que es el trabajo para poder lograr cobertura universal. Julia manda sus palabras para desearnos todo lo mejor en este trabajo y seguramente estará con nosotros en otra ocasión. Kathleen, please.
Good afternoon, everyone, and thank you so much. It's a real honor to be here. I'm going to be speaking briefly on opioid availability. I think you've heard from many people that this is certainly not the only issue, and palliative care is much more than pain management and opioids, but this certainly is a significant issue. So as you've already seen, there is a public health model by the WHO that has 4 components. So policy, education of officials, clinicians, students, implementation, and then, of course, drug availability. And I'm going to speak briefly on drug availability. So the Single Convention on Narcotic Drugs of 1961 is an international treaty that establishes a framework for control of opioid medication. But one of the very important components of this is the principle of balance. And there's a dual obligation of governments to prevent diversion, yes, but also it's imperative on them to have opioid available for patients as they need it. And so by this principle of balance, it's imperative for governments to both enable and empower clinicians to be able to prescribe, to dispense, and to administer medications according to the needs of patients. And it also says that while there is a risk of diversion, we cannot make our regulations so great that we limit the access to opioids by our patients. So the Single Convention also established this International Narcotics Control Board, and attention's been drawn today to the disparity between the need of opioid and the availability of opioid. And so how do we change this? So this enables the INCB in cooperation with government to support the balance between the need and the supply to the country. So the process is that governments must give the INCB estimates of assessments of the quantity of opioid that is needed. And so I want to stress that the INCB does not control the amount. The country controls the amount. The country submits an estimate of what is needed. And so this then allows the country to manufacture and import opioids as long as the estimate is not exceeded. And if the country finds that they're using a large amount of opioids such that the estimate may be exceeded, they can just submit a supplementary document and get permission for more opioids. So I'm sorry, I'll just say also that there are documents by the WHO that give advice on how you might come up with these estimates. You can use data from deaths, you can use data from physicians. There are also ways to look at what you're currently using and increase by a percentage. And I believe the group is going to be getting together to try to figure out what kind of estimates are needed for Mexico. I just want to say that even if you're able to get the amount of opioid needed, there's a difference between availability and accessibility. So even if you have opioid in country, you want to make sure that that is accessible to everyone. So everyone based on their financial background, you want to make sure it's not based solely in one area that would be very hard for other people to get to. And you need to make sure that there aren't onerous regulations on the prescribing rights such that clinicians can prescribe these medications as needed. And so I would just say, my experience in what I do, I'm a clinician and an educator, and it's really patients that drive me to do palliative care. And I just thought I would close with a story of a patient who I think really illustrates what we can do. I went to see an elderly gentleman who was in bed. He had terrible right upper quadrant pain. He wasn't able to eat or to drink. And our intervention was very simple. We gave him a small dose of steroid and 5 milligrams of oral morphine to take every 6 hours as needed. We were shocked to find when we returned 2 days later that this man who had been in bed and unable to eat and drink was sitting outside in his yard where his granddaughters were playing around him. Now, I know that palliative care is certainly not only pain management, but we needed to treat his pain and really decrease that suffering in order for us to talk about all the other suffering that was going on in his life and to be able to support him and his family. I know that most of us went into medicine or nursing because we wanted to decrease suffering. And seeing so many of you here today and talking to you, I'm really hopeful that Mexico will be a leader in palliative care in the future. So thank you.
Gracias, Kathleen.